We'll go to the presentation. I'm going to talk about a technique which many of us know already. Many of us might have done it intentionally or unintentionally. It is called subintimal angioplasty and stenting, subintimal revascularization. First described by Professor Raman Bolia in 1987, published in 1990. Subsequently, there have been conflicting reports that the technique might not be a very successful one, the patency rates are bad. But in our practice, we have found that certain patients, this technique can be well. Today, I am going to present three cases. One confined to the femoral SFA, superficial femoral artery. One extending beyond SFA to popliteal and probably proximal tibial arteries. Third, the lesion involving long segment tibial artery occlusive disease. So this is the first case. Most of our patients, please understand, they are not fit candidates for surgery. I am a die-hard surgeon. Any patient who is a fit patient deserves to undergo a bypass surgery. There is no second thought. Surgical bypasses are always far better, durable options for a fit patient. These are solutions for patients who are generally not fit for surgery. So if you can see, I will just come back to that. There is nothing beyond the SFA. Elderly gentleman in rest pain, cynosed foot, post PTCA, poor ejection fraction, nothing beyond the SFA. Nothing, no runoff. But we had done a scan, we knew there was a hibernating popliteal artery. That means the popliteal artery was patent, not occluded, but not filling because the flow was not good, the occlusions were too severe. There, we did the subintimal angioplasty, we created a loop, we pushed across the occluded segment, re-entered the lumen to find this patent segment. There was some amount of infrapopliteal disease, but without tissue loss in rest pain, we thought we'll do it, we'll accept the results. After subintimal revascularization, we plasty these occluded lesions and we even stent. Those two needles correspond to my entry and re-entry tears. At least two entry and re-entry segments, we have to do angioplasty and stenting. So it is pretty straightforward in femoral, especially if the disease is confined to femoral artery. Now, I had a 76-year-old lady who had come from Yemen. She had undergone intervention twice without any success. Her 4 children had left everything at home with their mother. They had come to India to get her treated. Now, 2 interventions were done, one at Yemen, I think the other one was Abu Dhabi, I'm not sure, but both the interventions were not successful. Both of the times they had tried to intervene and they had caused extensive dissections in the femoral artery. Both the times we had gone through the CD, they could not re-enter that true lumen. So that was what was challenging here. So as we can see, the femoral artery is completely occluded. Sometimes what we do when we are doing fluoro, the fluoro is not safe, so I could not show the wire entry. We came by subintimal way all until popliteal artery. Now after we came until popliteal artery, when we checked the angiogram, what we saw was we tried to re-enter as usual. 2 other people had tried, they had not seen, they had already extravasated. We had done an ultrasound scan, anterior tibial and dorsal pedis artery at the ankle and the foot were patent. So we knew that was our target vessel. So after several hours, I think by this time we had spent 2-3 hours on that patient and it was blind loop. We decided to go by retrograde. Under ultrasound guidance, we punctured the dorsal pedis artery and pushed the wire up. So it was not easy from here also. Once we got the wire up, we did an angio and we saw that there is occlusion of the anterior tibial, proximal anterior tibial artery also. We took the wire up, we thought we will go ahead and open up the anterior tibial artery from retrograde. Usually retrograde cannulations, surprisingly they are easier when we have a tough lesion on the top. So we tried that, tried for several hours again. Now probably we had almost 4 hours, we could not do anything. That is an occlusion I'm sorry, I don't have a pointer here. We could not. So it was taking on the fatigue was setting in. We even started doing retrograde below. We could not re-enter the true lumen. We tried literally everything that we had. We had support catheters, wires, coronary balloons, coronary balloons and everything. And at the end we had caused a dissection down also, the contrast started leaking. Now almost the devil thought that should we even give up like our colleagues to add to the misery, there were heavy fistulas here. The vein was filling. Should we give up that to other centers, but we did not give up. And with some more effort we saw that faint filling. That was popliteal artery, which is literally a thin hair-like contrast filling. So we chased that, and luckily we were able to negotiate the wire subsequently up. We were in false lumen. We had a micro catheter. We had access from the opposite side. So our regular catheters are 90 centimeters, could not come till here. The aortic bifurcation also was high, little tall lady. So we had to negotiate an 014 wire into a 014 French catheter, which was a Rubicon catheter here. So we were able to manage that. With a few attempts, the wire entered the 014 system, and then once we had the wire, we took it over and above and lost it out, or we got it out of the teeth on the opposite side. Now the moment we have a wire which is body clasped, entering through one side and the other side, we know we have almost achieved an angioplastiable candidate. Once we got that, we got this wire out because that was the only vessel for us, that was the only run-off vessel. We didn't want anything going wrong with that. We exchanged the wire, we angioplastied the entire segment in a graded way. We used smaller balloons initially, subsequently we used larger balloons. If I can have a couple of minutes more. So then we plastied, we used a 5 mm balloon plasti, and subsequently we did a stenting also. There were a lot of dissections, so we did a stenting for the segment, all until the proximal SFA. Now once that is done, the complete segment opened, even the popliteal segment opened and run off into the anterior tibial artery and even the foot. So if I have the time, I'll go to the next thing, otherwise I'll wind up.